Hi, Crystal. Hi, Leonard. Crystal, how is that doing?
Hey, how's it
Hi.
going?
Good.
I'm
Good.
I'm driving, so I'm gonna stay
You're
muted.
driving. Don't don't get caught by police. How's the weather, Leonard? Are you hot out there?
It's not too bad. It's not as bad as it was before. It's not like 108 degrees. It's like mid 70s.
Oh, okay.
But there is a lot of smoke though from the forest fires.
Yeah.
So yeah. So
We had when was it? Last week or maybe this Monday. I don't remember. We went bike riding and it was so smoky. I don't know where it was from. So people were saying, oh, it's coming all from, like Alberta and all the fires wherever they're happening. And then it actually became evident that we had some fires here in Ontario too, smaller, but they're ongoing fires. So it's likely from that.
yeah, probably. Yeah, here it's like so dry. It's like a desert, right? So,
Oh my God.
half the place is on fire. It's just like California here. It's just like, especially in
Yeah,
the
but you
summer.
don't have the wine, do you?
Well, like I said, you got the problem with air quality. Especially in this time of the year. So, like I said, it's kind of like Los Angeles kind of thing, where you got the poor air quality, because you got this low pressure system that's pushed by this high pressure system down, and it just kind of settles. And then, of course, this time of the year, of course, we get a lot of like brush fires, forest fires, you name it. So we get it all.
You get it all. Lucky
Yeah,
you.
sometimes even including earthquakes too. So
Yeah. Yeah, I know. Everything. Everything
and
we want.
torpedoes.
So I was actually wanted to ask you, did you manage to take a look at those exams? Any hope we can rescue some of that stuff, or what do we do?
Now, I haven't been able to solve that problem yet.
Okay.
Hopefully, this weekend I'll have some more time to look at it. To be honest, it's been just kind of overwhelming lately. A lot of projects and stuff like that. But like I said, I'll see what I can do. Hopefully, this weekend I'll be able to spend a little more time in trying to figure it out.
Yeah, I don't know I can't figure it out. They answered the questions, it just never got processed as, and then some of them looks like it kind of got the questions themselves. You can see that they were marked, but the final mark is not there. So I don't know. I mean, I can do it manually. That's not the problem. The problem I have with that is that it will not show on the website, right?
Yeah. Like I said, in the database, I should be able to extract the answers that were given.
Yeah, no. So I send you all the answers in email, so you just have to go back and retract all that.
Yeah,
But
right now I'm kind of trying to filter through the database, all the records, and there's like records and nested in records and stuff like that.
Like some things I managed to figure out on my own, and I did quite a bit of that figuring out things. But I think so. I don't know, is it maybe because there was a time difference or something? So some of these people got locked out. So I don't know if they hit midnight there, or I actually don't know what happened. So I just saw a couple of them that worked on the exams, and I've seen them. They were there definitely before midnight Toronto time. And then I went to bed thinking, okay, they're going to finish, so I'm just going to take a look at this tomorrow morning. And I come back and I see there is this glitch. So I wonder if it's because it was too late. They started maybe too late, and then one of them said to me, her task just got restarted, rebooted from zero. I can't even imagine the stress that girl was going through.
Yeah, I can only hazard to guess. I would have to kind of go through the logs and stuff like that on the server, and find out that way. But a lot of the times too, it's like a peering issue. Where the connection it's just a bad connection, right?
Yeah.
So
it's likely a lot of that as well, because from what I'm hearing, one of them, so we had a tornado touchdown here in Ontario. So one of them said, she actually emailed me days before. She said her area was without power for a few days and the internet is kind of spotty, so she may or may not get it through. So I knew about this one student, so I kind of accounted for her, but she managed to do it in Sunday afternoon. And then another one, she was actually from Alberta, she said she just lost power and internet, and she started working in it and it just couldn't go back. So I recopied exactly the same, because I didn't want to play with the settings in the original file, because I was worried I would mess up something. So I just copied exactly the same exam for her, and then when she entered, I had few of them follow through. Like, okay, I tried to put restrictions, but every time I would put restrictions for her, she couldn't do the exam. She would enter but couldn't do the exam. So I took away the restrictions, and when I took that down, we had few of them follow her into that exam. Oh my gosh. I'm like, okay, I know Leonard can fix this.
yeah, well, like I said, on the weekend I'll see what I can do. Digging a little further into that database. Like I said, you should see this database. It's like a rat's nest. The actual source code, it's actually quite the rat's nest. So I just kind of have to dig a little deeper into it and see if I can extract the data and that those particular tables and those particular records. So right now I'm just trying to search for those particular records, for those students, right? So, like I said, for you, as far as the interface goes, you might not be able to see any scores, but just because it wasn't completed, as to say, the system thinks it hasn't been completed, but a lot of the times it'll still retain that record, until it's been replaced or something like that. So that's what I'm trying to find out right now, is those particular records.
Yeah, I managed to download all the answers and save them in PDF. So at least we got that. So it's just for that, I guess, because it looks like what it reads to me, it says never submitted, and then I don't know. I think the system just got somewhat confused. I really don't know what happened there. But anyway, hi, how is everybody? Hello. Good. It's summer. We should enjoy this as much as we can, right? Has anyone ventured on any patios or anything like that?
Well, I did manage to get to the Stampede. It was the last day, but didn't quite get the pictures I really wanted out of the event. But no, I still got some pictures. I just haven't had time to make the montage and stuff like that. Did a couple interviews and stuff like that as well.
Cool.
So At least I got some content.
Yeah, no, that's good. We are looking forward to see
A
that.
lot of the stuff was closed when I got there. Like,
Oh, interesting.
yeah, they kind of cordoned things off and stuff like that. And man, was security ever heavy there.
Oh, good. I mean, I think it's needed, right? I think we
Um,
kind of feel like we forgot a little bit how to behave too.
Well, no, it almost seemed like they're, if you ask me, it almost seemed like they were expecting something. Like, maybe there was chatter. It's
You
like,
never know, right? Maybe
yeah,
someone threatened
um,
something, or who knows.
yeah, they had like metal detectors when you get in. They check your bags. It was,
I'm not opposed to that. To be quite honest, I think safety is
yeah,
paramount, especially when you have so many people, right? And I think
yeah,
we all have been kind of cocooned for a long while, so we forget
yeah.
to do basic social
Uh,
social
you might,
interaction.
yeah, you could be right there. But uh, and it was kind of weird. I had because I'm starting up this sort of different company, if you will,
Huh?
which is a media related organization, and so I've got these press credentials and that, but I never registered myself with the Stampede board, right? And as a member of the press. And so anyway, when they had us go through the bag check in the metal detector, of course I don't. Yeah, well, the way I dress sometimes and that, and I look, a lot of the times I look like a scrawny skateboarder teenager. So well, they never bothered really to check my bag. They're taking items out of other people's bags, and the guy just looks at mine, kind of, and just kind of puts a stick around in there a little bit, and he goes, "Yeah, yeah, you're fine. Go through." So
Goodness
get to the
gracious.
metal detector, and you have to put your hands up and go through the metal detector. So I had my camera in my hand and in my left hand, and I was going through, just about to go through the metal detector, and then the guy stops me and he pulls out that the wand that they have for
Yeah,
the airport, and so I guess he saw the credentials then, right? And he's going like, "Oh, you're working here." I go, "Well, I'm a member of the press, but I'm not registered as a with the Stampede board." And he goes, "You know what? Never mind. Just go through." Right? And so he has me go around the metal detector. So, but you wouldn't believe the stuff that you can do with a press pass. Like,
oh, I can imagine.
like
For
I
better
had
or for worse, right?
Oh yeah, yeah. Like people were, the people that were working there, they're, letting me go into certain places where most people wouldn't be able to get into, and then there was, being able to do the interviews, and even some assistance with the police force as well.
Oh, wow.
Yeah, yeah. So, yeah, it was kind of weird, the places you can get into and what you can do with the press pass. That's but yeah, it was kind of interesting to say the least.
Fun times. Hi, how is everybody? Hi, Vernette. Hi, Carrie. Hi, Kyle. I see some people are joining us, so let's give them a couple more minutes. So I just wanted to actually speak a little bit about the exam. So as you guys know from my email, we have experienced some technical difficulties with marking at the end. So few people that ended up taking the exam on Sunday did not receive their marks yet. So Leonard here will be looking over the weekend over this, so perhaps we can wrap it up at that point. So right now I was actually reviewing some of these exams, looking into the questions. I wanted to go over a few questions, not too many, just want to go over the ones that scored the lowest, and some of them really just boggled my mind. I think was what I was really confused about. Few of them, but what was what was so confusing to get them wrong. I think a lot of people got tired, and I know it's a lot. So the average mark is 7.63, and I think hi Simi. Okay, so Sharon, can you hear me, or we can just hear you? Let's see what she says. Maybe she can't hear me either. So I think one of the things that Kyle may want to share with us what happened, but in my testing the exam, I have not rerouted it back to hide the answer. So Kyle was the one that actually caught up the mistake on my part after I got so excited that he scored a pure 10, and I was so happy for him. So I shared that with everyone, and then he's calling me in panic. No, this is not right. So he was very upfront and honest, saying, "You showed all the answers." that's why I scored so high. Not that he would not score high. I don't think so. I think I just wanted to say he was very honest, and I managed to fix that. But I also at the same same at the same time, I just want to thank him for being very honest and actually alerting me on my mistake, and also shows that we're all humans and that we all make mistakes. And then I managed to go back in before anyone entered the exam, and we made a agreement that we will not tell anyone before people pass the exam what happens. So we can tell everyone. I think it's important for us to know that I made a mistake there, and that I wanted to share that information with you, so you don't think that. So there is actually no one scored 100% except Kyle. So no, you're all super IPAC stars. I love you all, and I just think you guys all done amazing work. There is some pretty amazing marks that I just remained absolutely impressed. Like Sharon scored really high, and Ali was right next to her, and Olivia as well, and Tanya. And Tanya was the one who, is she here even? She was the one who was so concerned, and some of you stress quite a lot, but I will say the average mark for us is 7.63 right now, and that's without the exams that we didn't manage to mark. So I know that will change, and I will report that back to you. But I think I was quite impressed actually with. I know that I have given you IPAC exam that was quite hard. I know it was in line with CIC, and I'm happy the way you guys all performed. So I hope that you feel the same way I feel about your success. The bottom line is, I had a conversation with another student who said to me, now we know where the gaps are. And yes, of course, so this is the point, is to also direct us in where are the gaps. And I will tell you, reading your exams and going through your answers, I will just urge you, when you go out to write your CIC, to give yourself time read the question, but also read the offered answers. So I will just go through few right now that as I said, I thought I was a bit confused. I will share my screen with you guys. Okay. Kyle, you're a superstar. Absolutely superstar. No doubt about that. Okay, let me see if I can switch this. Okay, so your first question that was, because I picked the lowest scoring questions to share here with you. So the first one that comes up that is lower scoring question was this question about the size of the microorganisms. And if you remember, we were talking about the viruses being the smallest. So you have a fungus, which are the biggest, and then you have two offered bacteria and a virus. So passing through this 2.22 micron filter, it could be only a virus, right? So if you were to think about, even if you don't know the information about how big is this particular microorganism, so if they're asking you a question and you have four options four different questions, four different answers rather to pick, and one of them is fungus, so those are the biggest. So that can't be. If the answer is only giving you one option, so it has to be one of them, then you know that viruses are the smallest, and really doesn't matter how big is E. coli or Vibrio in this case, so you're picking your smallest. So there's a little bit of that strategizing for the questions that you may not know the answers, so just kind of like beating around it, like what is that I don't know and what is that I do know, and applying that. So when you get your exam, I would say answer first the ones that you know for sure, park those ones that you may need to ponder upon, and then you can go back to these and then revisit this. So for salmonellosis, the precautions. There's no precautions for salmonellosis, right? So it's not something that is healthcare associated. It is usually a foodborne illness. So we are not putting patients on precautions in a healthcare facility that are identified. Once we know, if you don't know and you're ruling out, that's reasonable. But once you have a confirmation it's salmonella, you take them off precaution. So they don't need to be on precaution. So routine practices for any of the foodborne illnesses. So the third question that a lot of people were struggling with, and this is why I was really confused about this one. I know you guys, anyone who is working in the field, is that you are not sending C. diff, you're not sending stool for culture when you're testing for C. diff, right? So when we were talking about the sampling and what goes, so if you don't have a clear idea of what your patient could potentially have, then we are sending ova and parasite and culture, and we are sending for C. diff. And the test for C. diff is either toxin or PCR. So we wouldn't be sending C. diff when we are rolling out C. diff for stool culture. So it would be either PCR test or toxin. And toxin is the most common one, I would say, and then PCR would be most precise one. And every time you're sending your specimens for, like with in particular for PCR testing, so that's your gold standard. So if anyone is actually putting these questions out to you, so always think about also the cost associated. Is there a cheaper way to do and come up with a result? What is mostly broadly used across the spectrum of healthcare? So that would be probably your best answer. All right, so this other one, this I think is just, everyone was confused around this one as well. So this is just to count, really. You're just looking at the number of cases. So if you assume that horizontal lines in the diagram represent the duration of illness, we have 8 different people here. and the community is 700 people. So that's the population at risk. What's the prevalence of a disease during month of July? So July 1st is marked with this dotted line, vertical, and August 1st is marked on this side. So anything in between is July, and then past this line is August. So you're looking for all the cases that are documented in month of July. So we are looking at the prevalence in this case. So what is it? So you're looking into your 1, 2, 3, 4, 5, 6, 7, 8. So 8, so they're all here, right? So they all were accounted. That's your prevalence, everyone. So everything between these two lines you're counting. So I thought it was simple. I thought everyone's gonna get this one, but I think it got confusing with the dots and lines. Maybe I don't know what happened here. And then the next one is what is the next one? The next one is incidence. So it's how many new cases in month of July. So we are not counting the ones that started in June, right? So whatever is the new case in July. So you have 1, 2, 3, 4, 5. So these guys we don't count because they started in June. So I don't know, like maybe this is just confusing from the image perspective. Maybe you never saw these type of diagrams in your experience, but I know in this also, this study that I shared with you, the outbreak, the Hep C outbreak, they have a similar chart. So, and you can see how these cases are overlapping. It has nothing to calculate. You're just kind of looking at the number at these lines and count them, and just have to understand what it kind of look into the picture and understand that. Okay, so then the next one was to determine the probable period of exposure of identified cases to a common source during an outbreak. An ICP needs to know all of the following except. And I found this except was throwing a lot of people off. So any question that we had except, a lot of people missed. So I think you guys were looking to give the right answers here. So I don't know, but when you're investigating an outbreak, so index case, really, it's not something that we are so much interested. We usually find out, right? But we need to know the onset of the cases. So when did they start? When we start investigating outbreak, whether there is a connection or not, you have to identify where was the onset of the dates. So to identify whether there is a linkage. And then you also need to know the diagnosis, because what are we chasing if we don't know the diagnosis of the disease? So we need to have a confirmed diagnosis. And that's usually your first step when you start investigating something. We don't follow up on probable results. We wait to get confirmed results to initiate investigations. So that's your first step, always confirming that diagnosis. So if there was in some sort of an order, that would be your first answer. And then also you're looking at the mean or median, the minimum and maximum incubation period. So this is important, again, to determine when your outbreak started. And also once you're in an outbreak, it's important for you to know this so you can declare the outbreak over once we have passed that incubation and communicability. So that, I think the accept piece threw you all off on this one. Because there is a trend with these accept questions. And another thing also that I noticed, a lot of people had where we had the multiple questions and you would be able to pick more than one answer. People were picking only one, and it clearly says select one or select however many appropriate. And I think we didn't read these questions properly, so I can't, like, there are some of them were so simple. I just think that people, instead of scoring a whole point, they were scoring like 33% of a whole point or 50% where there was an opportunity to score higher. So when you sit down to write your CIC, make sure that you read the instructions, you read the question, and then also read the answers, because the answers they offer sometimes don't make sense. So you can kind of eliminate some of those that make no sense, right? Okay. So the endospores. I am just going to say this, C. diff. Why does C. diff? Yeah, I figured that you guys got confused over these over these multiple choice. So it's just, it's a good practice for you. I think this is a good practice for you to have a kind of dry run and see how is this going to be when you sit down to write your CIC exam. So the bacteria, the endospores, just think about C. diff. Why is C. diff creating spores? I had all sorts of answers, and no one actually, very few people picked, I should say, the adverse environmental stress. So whenever you find the bacteria that are spore forming, that are in an environment that is not um, supreme for their growth or in multiplication, they will create that spore and survive. You guys hear me? I feel like I got offline for a second.
I couldn't hear you actually for like the last 5 seconds or so.
You did for a bit.
What was the last thing you heard me say?
Environmental.
Okay. All right. It wasn't that bad. I thought like, my goodness, how long was I offline? Okay. Yeah. So the environmental stress. So that's, I didn't move too far from it. So just kind of think about it. They will not create a spore because they have too much food. They're not, although I feel like I should create a spore when there is too much food around me. Or they will not create a spore when they are looking to reproduce. So they're creating spores to protect themselves, to protect that inner piece of the microorganism, so they can, when the time is better, they can revive themselves. So I hope that helps. So the indirect transmission. So what is indirect transmission? Remember when we talk about contact, so you have direct contact and indirect contact. So direct contact would be a hand of a healthcare provider and touching your patient. So poor hand hygiene would be one of those examples. Indirect is usually a fomite. So you're looking at either like doorknobs or stethoscopes or any type of equipment that does go between the one source to potentially a receiver of the, so you have a host that is originally, or don't know they have something, and then you're looking into this microorganism traveling on these fomites. So that's indirect contact. I don't know what happened there either. So we got like mosquito borne, we got food borne. Yeah.
Only fomite. Like out of all the possible answers, it's only fomite.
Yeah. So indirect transmission. So your mosquito would be vector, right? If that's where we were kind of thinking about that. So they're actually defined as vectors, not as fomites. So fomites would be only that. So when you're thinking about contact transmission, it's always direct or indirect, and then under indirect is the surfaces, environment, shared equipment, and so on and so forth. So then we have this one, and I think this one confused you because, again, people didn't read the question. I think number 9 was you read it as MRSA because the answers picked were in fitting with the MRSA. So when you're talking about Staph aureus, they don't need to be on any precaution. Staph aureus is normal flora for about 70% of population. So anyone who tests positive that nasal rectal swab is positive for Staph aureus, well, that's kind of expected, right, in about 70% population. So we don't isolate. Okay, and then the last question I picked, an infection preventionist is asked by employee health, which is your occupational health, to devise a department specific policy for screening and control of communicable diseases. Which of the following diseases is most likely to be acquired by lab personnel? So TB. TB is the huh. Can you hear me now? Okay. I don't know what's like. I think I have a bad connection on my end here, so I don't know what's going on. Okay. Do you see the screen? Okay. So there's like a mixed bag here of answers. People can see, people can't see. Okay. Yeah, let me start this and then start again. Right, so I'm gonna read. So that's the last question. It was about the TB, right? So TB puts your lab personnel at risk. Okay. So if you think about Legionella is not something that is easily picked up. You have to have the water source, and you have to be exposed to that mist of that water source. Herpes simplex, it's either contact or airborne. Herpes simplex is always contact rather. With any herpes viruses, they would not be touching that with bare skin. Measles, again, airborne, and the TB would be your only one that is putting them at risk. So they're handling the specimens, they get aerosolized in the lab, and we are really not sending for measles, so we are not sending specimens in the same fashion, or Legionella is urine. So just think about, like, just kind of take a step back and think, what do you know about some of these organisms? And even if you don't know the answer straight up, try to dissect it, break it down to manageable pieces. Okay, so I'm gonna stop sharing the screen now. Hmm. Can you guys hear me now? Okay, I don't know what's going on. I can't stop sharing my screen. Let me disconnect and come back in, okay? I'm back. All right. So, and then we had some discussions this past week over some additional questions that we had there. We had posted some questions, talked about that hepatitis C outbreak. Last week we talked about epidemiology. So as I said, we will be kind of moving in a similar direction. Oh, and I wanted to share something else with you guys. So I have a friend who just wrote her CAC exam, and what she was telling me was they had a lot of construction questions. So we will be covering that in I think it's our unit 13 or 12, if I remember correctly. So we will cover that. Next week, we will be talking about pandemics and bioterrorism. So she had quite a few questions in relation to pandemics, of course, but she said there was no mention of COVID in particular, just generally talking about bioterrorism and organisms that are often related to bioterrorism. So we will cover that next week. And so she said, of course, it was epi heavy, of course. So there was a lot of these mean, median, rates, and proportion questions. So make sure you learn those definitions and be able to recognize, again, these questions that are posted to you in terms of reading them. So we had a question that Sharon sent to me. I posted that. I saw Marina and Olivia answer to that, but I don't know if anyone else got involved with reviewing that question as well. Let me pull this up. Okay, where are we? Week 8. So I was asking Marina if she could elaborate how did she end up with that calculation. Okay, so yeah, so I think this is you answering in the at the bottom here. The I don't see the names who is actually posting to me. So thanks, Burnett. So I want to share this with you if I can as well, and try not to get frozen again. So the question is actually what's the what's the additional number, right? So the question reads, in a community outbreak of gonorrhea, out of the initial 40 cases, the ratio of female to male cases is 3 to 5. If 120 total cases are projected and the same ratio persists, so 3 to 5, how many additional cases? So I think for Sharon was also that this was the additional piece that was, so you have to read the question, right? So if you're looking in, so Marina gave us an answer here. She says it's, I think would be 30, but I'm going to share, I'll try to pull this up for you. Okay, that's not the one. Okay, this is the one. And I'll try to share the screen again and hopefully don't mess up anything. Okay. Okay. Okay, here we are. So if we have this group of 100 and however many was the question. Sorry, I'm missing this here. So you guys can see it. Here. Okay, so it says in the community, so we have this ratio. There is originally 40 cases, so then we got the projection is we are going to end up with 220 cases. So that's they're projecting. Someone came up with this calculation. So if we have this group that is the ratio is 3 to 5. So we know we have in a group of eight positive humans, we have 3 females and 5 males. So now you kind of create how many of these clusters of 8 can you fit in your group of 40, right? So then we know that we have now 5 groups of 8 people, and within those groups we can break it down. So now we know the ratio is 3 females. So if we have a group, we have a group where is 3 females, 5 males, and we have 5 groups. So what does that tell us? It's 15 females in a group of 40 is 15 females, and that makes up for 25 males to maintain that same ratio 3 to 5, right? So now we know something. We have finally come up to some numbers, but that's not the question. They're asking us what is the difference, however many more females are we expecting here. So we know now that we have the same ratio. So we also have another known. It's going to be a group of 120 people. So, and we have to still create these groups of clusters of 8. So maybe they know somehow each other. I don't know, but that doesn't matter. So so however many these little clusters of 8 we can fit into the group of 120. So you can have 15 groups of 8, right? So now we know that there is 3 gonorrhea positive female in each group. So that's known fact from the get-go, and 5 males. So now we break it down is 3 females and 15 groups. That equals to 45 females in a group of 120 and 75 males in a group of 120. So now we know also what is the makeup of this projected 120 group with that ratio. So now they're still asking us how many more. So in original group we had 15 females, and in this projected group we have 45 females. So the difference is 30. That's 30 more females. So I don't know if this makes sense. If that, I tried explaining it in a colorful fashion here to help you kind of follow this through. I will post this in that conversation we had. I think this would be a little bit too time consuming to have something like this on your exam. But I think it's good to kind of exercise your brain to get comfortable with this and understand how this functions in a statistics world. So what is critical is that you have to understand what they're asking you so you can pick the right answers. So if you don't understand the question, you will not be able to answer it. So take your time, read these questions, read what they offer you in the answer. So sometimes it's easy to eliminate some of those options, and then you can just kind of figure it out on your own sometimes. Or you can be like some of those superstars that are scoring A+ on the exam, and they don't need any of this help. All right, so we're going to talk about surveillance today. Are you guys ready? All right. So as we start every class, we will talk about defining what is it, what are the goals, and I will take you through this lecture, but I am 100% positive you all know this because this is our bread and butter. So if I was to ask you guys what is surveillance means to you, how would you define surveillance? What would you tell me? I started worrying that I fell off internet again when I haven't seen anyone responding. So what's surveillance for you? Mm-hmm. Yeah, exactly. Very good. So when there is again definitions that I share with you, sometimes I think they may come up and creep up around for you. Sometimes I think they will not. But this is the one that I have learned when I was a wee little student back in Serbia. This was the World Health Organization definition, and it stuck in my head for so many years. And I thought, I think this is something I can actually share with you. And what's really important is that it's systematic, ongoing collection. So it's done in a very organized fashion, and it's an ongoing collation and analysis. So we're collating all this information that we collect, and then once we have gathered the information, we analyze it. So back to simple things like hand hygiene programs. If you're collecting numbers and you're not following up on it, it's a waste of your time. It's not a good use of your time. For any surveillance, it is, as I said, our bread and butter. It's what our jobs revolve around. It's absolutely. All right. Can you guys hear me now? Sorry for that. I'm not sure what's going on. I have a horrible connection today. I guess I'm just lucky I'm not writing the exam. Okay. Hello? Can you guys hear me? Oh my gosh, I switched it now network. Hopefully we don't get kicked out. I had to switch quickly network, so just bear with me here. I apologize. So just back in time. I know this is gonna be. Hopefully, it's not gonna be the nightmare that is going on all night long. But let's just move along and see where we end up with this. So it is designed in accordance with our current recommendations. So whenever you are setting up any of your surveillance programs, always follow up the definitions and any of the rules that are set for us. So usually we line up with the best practices of course, here in Ontario, Public Health Ontario, but there is also programs that we are asked to review from Ministry of Health mandates. The Quality Ontario provides with some guidance as well. There is also the Accreditation Canada is asking us to meet certain requirements in terms of what are the mandated surveillance programs. So one of the mandated surveillance programs across the board is hand hygiene. So you will see that all hospitals are reporting on hand hygiene, but also you will see like your are often mentioned to you. It's the MRSA and VRE bacteremias and C. diff. So those are all available for public viewing. So you can screen all the hospitals in Ontario through Quality Ontario, or you can go to any of the hospitals and look at their quality data. So that's where this would be sitting, the statistical piece. So this is why it's important for us to know first what is a must, and then also in line with the capacity that your facility has, you design your program. So as I said, some things are given and a must, and then some things we decide based on the capacity that we have. So I have posted in, and I will not be sharing any screens anymore. That's it. I'm done for now. So in the lecture for today, there is links to resources that we use, and you will be using them also for outbreaks, identifying outbreaks, and so on and so forth. And also when we get to week 11, we will be using some of these documents again for the occupational health piece. So back to our surveillance, a little bit of a history. So looking back as in the 460 before Christ, Hippocrates actually has also investigated and rationalized links between the environment and humans. And there is actually a paper, there is a book he wrote, and I was reading while I was preparing this lecture for you, and some of those things are quite relevant and eerily so relevant to us and current states, and some of these things are just quite comical actually looking back, but knowing that they didn't know about the existence of microorganisms, the ability to link the environment to human outcomes was just absolutely mesmerizing. So if you can find a book, it's actually on the internet. I can share a link with you as well. It's a part of common knowledge and part of common access. So it actually is called Air, Water, and Diseases. So I will share this with you. It's kind of interesting how things were perceived back in times. And of course, you know, Samuel Weiss was also another person who had a significant impact on surveillance. If you think back to that, the hospital, the Viennese hospital, with the mothers who were dying postpartum as a result of the physicians performing autopsies on cadavers, of course, and coming back into this, and his ability to observe this and find the links, it's absolutely amazing to me how people without ability to actually know and see what we see now, how they were able to find the links and find the epi links. And of course, you guys know about Jon Snow, the London and cholera outbreak, and his ability to link that pump that was culprit for cholera outbreak. So those are all kind of fathers of the surveillance and epidemiology, so to speak. But also looking kind of in a little bit more modern history, we are looking into 1958, when the American Hospital Association actually has stepped out and officially recommended that all hospitals in the states, they have established program, a surveillance program that is actually looking for these healthcare associated infections. And then in 1976, the Joint Commission first included actual infection surveillance in the requirements for the accreditation. So relatively new, not so new, I guess, depending on how we're looking at the time. But it's kind of interesting to see how little progress in terms of timelines did we make from 1976, and then how things are still didn't budge at all from the Hippocrates time. So something to just ponder upon. When you look into your elements, if you start to contemplate how to build a surveillance program, or if you're asked to start conducting surveillance on certain elements or certain microorganisms in your facility, what you need to know is how do we get there, right? So we should be able to detect and monitor. We have to be able, from the information that is in front of us, to be able to identify the risk factors. What are the risk factors for the HAIs? We have to include evaluation of these preventative interventions. So the entire idea of collecting information is to identify the gaps and address these gaps, and then go kind of back to it and count again and start completing your surveillance again. And the last piece is kind of, I always think about it, a first piece of a next step. I see it more cyclical than linear. So when you look into your into elements, once you're done with collecting information and providing education and reinforcing, you start detecting again. So it's kind of a cycle, because you're always looking for improvements, and you want to measure how did your interventions actually perform, whether you were successful. Okay, so as I said, it is an ongoing systematic collection, analysis, and interpretation and evaluation of health data that is closely integrated with timely dissemination. So again, when you are asked to go and present to either your IPAC committee or the board of directors, so you have to be able to produce this information and be able to speak about recent events, and do so in timely fashion. So you don't want to sit on this information, and then when everything kind of settles down and people are focused on a different problem, you come up with these reports. So you want to be always on time. Some of these reports, you may have something like schedule reports, on maybe quarterly or annual basis. Some of them you may be producing after outbreaks or some sentinel events, for example. So as I said before, these are all kind of your definitions. They're coming from Public Health Ontario in this particular case. So they're all speaking about this organized and ongoing component. So I think it's repeating itself, but it's obviously important that we speak about it as being a program, not something that we kind of pull out of and dust off when we need. So it's an ongoing program. It is involving complex information ways of collecting. So you would be looking into your laboratory results. You may be looking into something like syndromic surveillance. So any type of information, but it's constant. Every day you're picking at it and looking at your numbers. You may be dependent on some support mechanisms. So it could be your lab results, could be your charting systems. So there is different ways how do we get this information, but it's what we do with that. Okay, you guys still hear me? I guess no one's complaining. I don't see anyone typing down there, which is so strange. I get off the network and then I still see you typing telling me I'm off, which is good. Okay, so the elements of surveillance, that's exactly the same slide that I actually put in before. So when we're talking about detecting and monitoring, you need to be able to establish a baseline and be able to establish the rates. So this is why epidemiology is important. Statistics are important to us. So we can calculate these rates as well. But also when you're looking into the establishing these baselines, you have to also revolve back and revert back to those definitions that I was mentioning to you before. So when you're establishing your baseline, you have to go and look at this case definition to first determine whether something is a healthcare associated case. When you're looking into your risk identification, so at this point you're looking at where is my problem, right? So where is this coming from, and what are the potentially risk practices or risk creating procedures. So for example, you could be looking into something as surgeries or indwelling catheters or use of antibiotics. So those are all the factors that will be contributing to higher rates of healthcare associated infections. It doesn't mean you knock them off. It just is something to be aware, and maybe this would be something you can work on to reduce these rates. So the next bullet speaks about evaluation and preventative intervention. So that's anything you would do to reduce the HAI. So you could be as simple as teaching hand hygiene, or providing education on cleaning of that shared equipment, for example, or could be something as complex as surgical site infections and involving a number of expert staff, or use of antibiotics and reduction of use of antibiotics that are unnecessary, or shortening the time. So you would be collaborating with different teams on this potentially. And then once you get your kind of ducks in a row, you are putting all these measures in place, and now you want to measure and go back to probably involve more people as well, as your program is gaining on strength. So you want to have more of your grassroots involvement. All right, so I think this is where I speak more about this, how I see it. This is just my idea of this cyclical, constant, ongoing program that is constantly moving. So again, you're starting with assessing your population. So who is that you're looking at? It could be something as only people that have had surgeries, or only women on maternity ward, or could be only pediatric population. So you pick who are you looking at, and then you're looking at these outcomes. So what is it you want to know what's going on in your units? Are you having surgical site infections? Are you having serratia on your units in NICU, for example? Or is there any surgical site infection? So anything that you can narrow down, this is the process, how you figure out where do you have a problem. And for us, we kind of always like to look for problems, so we're kind of annoying to the rest of the people, but we are always looking to improve. So I think instead of saying we are looking for problems, we are always looking for improvement. Perfect. Thank you. Suddenly you just all got quiet and I'm worried if I fell off. So it doesn't look like I fell off, but I don't know anymore. Okay, so we always have to use our case definitions. It's used consistently over time. So we can't be switching our case definitions. I mentioned this before to you many times. So we are always sticking to the one set case definition. Sometimes you will see that there may be different reasons why we have changed the case definition. Could be that the case definition got changed on us. Could be that usually during the outbreaks, sometimes we may be directed to change it and change it so it's including more population. But sometimes it's just best sticking to the original case definition. It's not necessarily best. I said that wrong. It's probably easiest for us to stick, but sometimes we need to change it. So if you are dealing with a population that may not be typically presenting with typical symptoms, so you would be maybe kind of setting up that case definition somewhat broadly. That comes with the risk that you would be catching people that are not part of that are actually not affected. You're just catching some of those cases that are somewhat similar in presentation, and they may not actually be true cases. So once we have the information, of course, we calculate and do the analysis of of the data that we gathered. So usually I personally always put this in Excel spreadsheet, always create them in some sort of line list, and then do the at the back of my spreadsheets, I do these pivoted charts, and it helps me really get information really quickly when people need them in a nick of time. And usually it's someone scratching at the door a minute before their meeting and they need some of the stats. So for me, it was always easy to have this on the go, and I can just extract what I need. And also for me to kind of have a quick overview of problems that may be, and if I see something trending on one or the other unit, I can quickly take a look and see if that unit has had history of problems in the past. So that's how I do it. It doesn't mean that's the ideal and perfect world. It's just something I do. And then also, it's important when you get into the data collection and sorting it to use the risk stratification when you can do so. So some of these would, of course, include your like surgical sites, your VAPs, and your catheters, indwelling catheters. So those would be all that you can stratify by. So it kind of narrows it down, provides you with a more specific population, very narrow and very, very clean data, I would say. So what do you do once you have the rate? So now we calculated all the possible incidences and prevalence and attack rates and whatever is happening on our units. What do you do with that? How do you interpret this? So for most part is we kind of tend to stop there, and in a good program you want to continue. So what does that mean to you? What does that mean to program managers? What does that mean to the frontline staff? So everyone will see the number and see it differently. So it's important for us, sitting with the knowledge in our hands, to be able to interpret that information to people who are on the receiving end. So for you and me, this may mean this is a blip. For someone else, they may be running around losing their hair, or I don't know what people do when they're stressed. I might hear eat gallons of ice cream. Others are crying. So hopefully we're not creating any of those problems at work. That's just for me here in class to make you all cry for the exam. But but it's important for us to be able to read this information and actually make sense of it, instead of just giving them percentages and giving them sheer numbers. What does that actually mean in some goal setting environment, so to speak? So whether we are having a problem or not, we always want to improve. The goal of anything we do is always improving and having less of infections or less of colonization. So how do we get there? So you always have to have your partners in crime, so to speak. And if you are looking into improvement, your quality department, your risk department would be really good for that as well, to talk to them if you're seeing we don't really have a problem, but we could do better on this, or we could maybe partner up with some of the surgeons and just talk about some of these the data that you have, and talk to them with regards to maybe changing some of the practices that so we line up with the rest of the community. Or if we are leaders in something and we are not having any problems, we probably should look, why don't we have any problems? Because there is no healthcare without problems. So that's my take on that. If something is perfect, just dig deeper, you'll find it. So always make sure we share this. So that could be something you would do in a type of a report, or put it up on IPAC webpage, or you can print out the reports and put them on the unit so they can see it. You can do celebrations around some of the successes. People usually like that. After we put them through torture, they like to be recognized. So you can do some of the recognition sometimes. So you want people to enjoy our surveillance programs rather than fear it. So if you can always attach some sort of positive experience at the end of the milestones, or reaching certain dates, or reaching certain numbers, so recognize people that work hard to help us get there. And always evaluate your surveillance system. So if, as I said, if your numbers are perfect, if you're not having enough data points, or you're always at 100% of hand hygiene, that's impossible. Or you have absolutely no MRSA cases, or you have absolutely no flu transmission, something is not right capturing this information. Just from walking around the units, how many potential risks there are and what potentially could work out. So I would go back and take a look at the surveillance system. I know. You know what? It's interesting when you say that. Every time I think about surveillance, the first thing that pops in my head is cameras. And it's not statistics, it's not the swabbing people, it's not the surgical site infection, it's cameras. Every time someone mentions surveillance, and then I have to kind of self-adjust to the topic, what are we discussing here? But every time I think of cameras and the big brother. You're absolutely right. So the methodology that we do apply when we are doing the surveillance, it depends really on the goals. What is the end goal? So you can have something like total or whole house surveillance. So usually you're looking at the entire population in your facility, and then you kind of can stratify that information. So depending if you're looking for central line, or you're looking for surgical site infections, so that would be, you include the entire facility or the entire hospital if you're multi-site. When we start talking about the targeted surveillance, I find usually in the smaller facilities, that's what we tend to do, a little bit more of that. So we kind of tend to do more with the catheters. Like your long-term care facilities are very comfortable with this targeted surveillance. You can also do targeted surveillance for, say, ICUs, or where you're looking at the VAPs or urinary catheter infections and such. So, and then you focus only on one unit, or you focus only on one program, or so you kind of have a certain population in mind that you want to focus on. And sometimes we do that if we see that they may not necessarily be in an outbreak, but you're kind of always on the edge, and there is every couple of months something happens, and you can't really write it off 100% that is not our problem. So you kind of start looking at what is going on with this unit, what is going on with this particular program, and then you kind of do something like a prevalence, or you can do auditing and gather information from this particular unit to see what's going on. So you can do something like environmental audit, you can do hand hygiene audit, you can do PPE audit. Depending on what is that you're identifying to be a problem, you can do something like screening your sinks, for example, for CPE, or you can do patient screening as well, and seeing whether we have something that's happening and we weren't aware of this, and then it's just popping up. Usually tends to be with some of those long stay patients that we maybe have implemented a new screening protocol, and they have been there before we started screening, and they kind of got missed, and they're the ones that we are picking up on the and spreading the microorganisms from them. So it's something to keep in mind like that. You can have, of course, your combination surveillance. So usually when we decide on what we are doing, it's driven by some of those factors that are already creating some of those problems for us. So you already have something that is either happened or is being dictated to us by some sort of agency, or public health is asking us to do it. Sometimes we can be a part of a research project or a study, and then we start looking for things. So those would be types of surveillance that you would be involved with. The monitoring event, so that's not the event that Leonard attended. So those are different events. So usually we are looking at the type of healthcare settings, population that's being studied. So we have to have a good understanding of, first of all, who are we serving? What is our catchment? Understanding who are the patients that are coming. So as a more of a general understanding, and so be prepared to be dealing with some of those problems that are related to this particular community. So we have to understand who is our population. We have to also look at the procedures that are performed and services provided. So you are not going to be looking for eye infections if we are not providing eye care in our facility. If you end up with having eye infections from in your patient population, definitely something to look at. What happened? Where are they picking this up from? If we are not providing some, if we don't have an ophthalmologist on site. So just thinking about what is actually happening on in our facilities. In larger facilities, you have to know what services, what clinics do we have in our facility, because sometimes we don't know all about all the clinics. It sometimes there is like a random little closet that someone provides some consultations in that little space, and you just walk by and find out, oh, I didn't know we offer this and that service. So it's important for us to know what type of services we offer as a facility, so we can be prepared to provide support to them. Of course, acuity of care makes a big difference for us, so, and big difference for our patients as well. Risk assessment that identifies the risk factors for infection and other adverse events in the population studies. So what are these risk factors? So could be anything from diabetes, could be age, could be gender, could be socioeconomic status. So there's a lot of factors that do play a significant role for us, but not necessarily that we are collecting that information. It's just more for us to know. And then if it becomes important, then you're kind of including this into your reports. But generally speaking, a lot of these risk factors are kind of sitting there in the background information. Sometimes you will use that also to filter your information. So for example, would be in your, so say you're in a long-term care facility and you have a dialysis patient and they're going off site 3 times a week. So this would be a risk factor, not only that their dialysis and their health is at risk, but also the additional risk is that they're leaving your site, they're going into another facility, they're going to be exposed to a group of people. Usually these are the same cohort of people. Sometimes they do change, but generally speaking, it's the same people that are meeting on regular schedule. So it's same group of people in same chairs. However, it's important for you to know if they're coming from another facility that may have an outbreak there. So now your patient that's went down there may be bringing this home to you. So a lot of kind of monitoring and keeping your eye out on the community as well, not just whatever happens under our own roof. So of course there's these agency requirements that I already mentioned to you guys before. Usually we have recommendations and the expectations and requirements, but sometimes you will see that it may vary from, like in the states, from state to state, but in Canada here it may vary. Some of these recommendations may vary from province to province. And also at the beginning of this class, I remember talking to some of you and you were telling me how you find that your local health units have stricter rules than what is the provincial recommendations and provincial directives to us. So just kind of keeping in mind that there may be discrepancies there as well in terms of the expectations. And if you're ever asking yourself which one you need to meet, it's always a stricter. So always go with the stricter one and you will not make a mistake. If you follow the loosey-goosey ones, you will be missing on some of these recommendations coming from another agency and they will come back and ding you, and we don't want that. So we're also looking at the available resources, whether from personnel, so if you have enough staff to conduct surveillance, also looking into the softwares that are available to us. So some places will have like super duper epi softwares that you can process this information. Others will have a blackboard and chalk. So anywhere in between we can find ourselves. And also, what are the public health needs? So when we speak about public health needs, we're not talking about the requirements from your local public health units. We're speaking about the population that are making up the public health outside of the walls of our facility. Of course, the performance improvement initiative, so that could be something that may be either driven on the unit or could be something that could be facility-wide, could be something that is across number of facilities. So sometimes you will find hospitals will create these networks and they will work together in reducing certain rates in community or rates within their own facilities. So one of those that I can kind of think off the top of my head is the collaboration collaboration between Markham Stouffville, Mackenzie Health, North York, South Lake here. I don't know if there was another hospital. If there was, I apologize, but those are the four that are on, and they worked together in reducing C. diff in particular. There were other initiatives that they were working on. They were not IPAC related, but C. diff was in particular something they worked together. So that kind of gives you an opportunity to work with other IPAC teams and take a look at practices that you have in your own facility and see how are you measuring up. So it's kind of nice to have that support system from the other facilities, and you often find out that first of all you're not doing anything wrong, and second of all is that everyone battles the same battles. And then of course the organizational objectives, as I said, it could be something that is unique to your facility. You may be working in a research facility and they're doing a lot of research, and they do a lot of collaboration with the universities and government agencies, and they're pumping out all these reports. They're teaching hospitals. They have a lot of resources, a lot of students, a lot of PH candidates who can bring so much more than when you're in a smaller facility and you are at the jack of all trades. So not necessarily that we can compare ourselves with them, but we sometimes can actually piggyback with them and join them on their research. I've done it in the past, and it's pretty cool when you can use all their resources and all their money. So this is just another view of what I just spoken to you about, and there is nothing you don't know, but basically it goes back to what I say when I think about it. I think it more kind of in a cyclical fashion. So that's how I see that it works as well. And I think it's maybe actually at this point brainwashed, because I'm probably seeing this way too many times. It is described in such way, but I also work in this fashion. It's kind of like a hamster on a happy wheel, never come off of it. Okay, so here is one busy slide, but this is just the examples for you to see what are the outcome events versus process events. So when we are looking into surveillance, you're always looking at what are the end results that you are looking at. So you could be looking at your outcomes, which are your healthcare associated infections or TB skin test or sharp injuries, where in the process you're looking at something that is kind of more of a continuous in a way. So you're looking at adherence to your routine practices and additional precautions. You're looking at the skin testing, but not in terms of result, but in terms of the process that's been ongoing, and that we have a program that follows our staff from the day they're hired, that we are asking them for the skin test, and then moving through their employment if they have been exposed, that we have a program in place. A good example for this is also hand hygiene, also your reprocessing would be another one. So those are all the process events are speaking about these ongoing processes that should never really stop, and that you're observing and part of the assessment for them. And sometimes we are invited by a number of different programs to participate and help them either understand the information or lend the IPAC perspective on their own components of their own program. So reprocessing would be one for sure. Your occupational health partners would be another one. Housekeeping as well. And then also when you're looking in the collaboration, I like to call it collaboration, but we don't really have a choice, is the reporting of communicable diseases. So we are mandated under Health Protection Promotion Act here in Ontario to report. We talked about this in, I think, maybe in a third unit about this. The process of reporting and where it goes, it all ends up actually being a part of the global reporting, where we can follow trends and we can see the hot spots with particular diseases. So that's how we know where are the certain diseases hot spots, like TB, Ebola, HIV, or whatever is that we are actually reporting into the our local health units, and then it goes, so we were discussing this, it goes into IPAC system, and then PHAC uses this, reports this out from the states. It goes through CDC, of course, and then CDC reports this to the World Health Organization. Sadly, not everyone is a part of it, but that would be a surveillance on a broader view, so to speak. So how does this look from as small facility as any of ours to and what happens on a global level? So you're ready now to start with your surveillance. We need to kind of look at what is it we need before we hit the road and start the surveillance. So we have to figure out what is the time period that we are observing something. It could be an ongoing, and if it's ongoing, you will break it down, but usually makes sense by month, quarter, or annually, or by year. So back to these, what are we collecting? So it has to be a case definition, or has to be a positive result that fits into that case definition, or it could be a clinical presentation. So for your clinical presentation, you would be usually talking to physicians and nurses, reviewing the chart. For your cases that are dependable on the positive results, would be your lab results, for example. You also want to collect demographics, so you can sort out your data, your patients, so to speak. So you need gender, age, the medical record numbers, location, where are they, where were they. So you want to follow them also through the journey when they come through the door. And especially important if you are following up on any other communicable diseases and potentially following up on exposures. You also want to look at determine the methods for data analysis. So what is it, how you're going to calculate these rates? What kind of rates are you looking at? Often this is already predetermined for us, so we know how are we calculating these rates. It's set in the definitions. So it's either, as you know, for the incidences is a number of new cases over the number of cases at risk. So if you're looking into a unit of 34 patients and you have new healthcare associated cases, that's what you calculate. So all of that is, well, I think will make more sense. These rates that kind of isolated on their own, I find look quite scary. But once you kind of think about it, what do we do with this? It makes sense because you're doing it every day. So we may not be able to think in such fashion that we think about when we calculate these rates, this is incidence, this is prevalence, because it's just not something that we are accustomed to use the terminology, but you're doing it every day. So there is no ifs and buts about that. So you are, and we just have to kind of find those connections and put these pieces together to click in your head when you're going to write that exam. You will say, oh yeah, I know, I did this when I had my flu outbreak. This is the new cases that I had on my whatever south wing of fourth floor. I don't know. Okay, so that's when we are looking at how to calculate. And then also it's important for us to know how are we collecting this information and where is that information coming from. So as I said, depending on what is that you're collecting, that's what is going to be deciding factor on you to help you determine how you're going to collect this. And then at the end, you always have to create your report. So all your work is wasted if you don't produce a report and share that. And I find with a lot of IPAC, we kind of are somewhat shy, I think, but also we are worried about that reaction. How may our colleagues react when we send them these reports, and how they're going to feel about this? Are they going to be upset? I think it's important. Transparency is important for us to share and say this is the findings. It's not the end of the world, never is. We've been through COVID. Obviously, it's not the end of the world. We all can attest to this. But what do we need to do to fix the problems to get these numbers down? So that's all the purpose of the report is. Or if there is nothing to fix, just share the report and tell them they're doing a good job and to continue doing that. You have to know who to send these reports to. So who is your target audience? That too will depend on where is the report, where is the surveillance being completed, who are the affected units or programs. So you want to send this always, always, always to your own team and your management and your directors and whoever is up the chain from you. But also the way I work on these reports, I always keep two individuals very close to me. One is my manager, my direct report, who I report to, and the other one is the manager of the unit. So we work very closely together, and I keep them abreast of developments, so there is no surprises, because any conflict that you ever will encounter is because of people get surprised and shell shocked when you deliver the news in a room full of people and you say, oh wow, we're on an outbreak now, Burnett, we're calling an outbreak on your unit. And Burnett is like, what? I have no idea, no one ever told me anything, I haven't been involved in this conversation. So that's usually how the problems start, and you don't want that. You want to have strong relationships with your coworkers and with your colleagues, and they will respect you for sharing that information. People like to know. Doesn't matter how bad it is, first tell me so I can gather myself before we deliver the news to the world, right? No one does, Burnett, no one does like those surprises. And then again, as I said, make sure you always review your program, and whether it could be even within the process that you're working, and something may not be adding up, so you may have to tighten up around the surveillance that you're putting in place. So a population survey that we already discussed this. I said, who is in your catchment area, sociodemographic status, what is common diagnosis. So often you will be able to kind of understand, are they coming in with cardiac problems? Do you have a large dialysis population? Also, depending on the facility that you work in, it could, like, I'm sure Vernet doesn't see a lot of pregnant women coming in, but it could. I don't know. It could be, but usually, based on your own facility, what can you expect. And also, depending on the programs and the services that your facility provides, you can expect certain type of population. And then sometimes there is the unexpected, of course. So this is all very, very known to you from just kind of looking at your own patient population. So you can kind of really quickly sort this out in your head. However, we have to write this down. We have to sort it on paper or in electronic database to be able to filter this. But whether your population is aging, or is on this unit younger population, is this cancer population, is this my surgical floor? So some of these things right off as without even thinking about it. And then sometimes you just have to take a little bit deeper dive and actually collect that information, and maybe do involve frontline staff to gather some of that information for you if it's not something that is already in patient's charts, for example. So this last bullet, I'm thinking it's also for if you are in the pockets where say the vaccination rates are low, so you may see that there is some emerging or re-emerging diseases in your community, like measles, or I think now with COVID, everything is just messed up. I think we forgot to think about those things, but there's a lot of pockets in Canada that you may find some of like hotspots for certain organisms, like CPE, for example, or as I said, measles. It could be also TB, for example, or you could be seeing a lot of like sexually transmitted diseases in certain communities. So it could be something like seeing a lot of chlamydia, seeing a lot of syphilis. Not that this would be something for us from the healthcare associated cases problem, but just something you may be involved through your infectious diseases clinic, for example. So depending on where you work and what your facility, what type of services your facility offers. If you had a HAI chlamydia case, well, I think you would have a different problem on your hands. So when you're selecting your outcomes, right? So in acute care, we usually are thinking about the reports that are being pumped out on an annual basis, and we are collecting information daily. So sometimes we don't even think about it because it's just so automated nowadays. So it's either a fax machine is printing these reports for us, or a lab is sending emails to us. So we don't really think much about how are we collecting this, but it's done usually on daily basis that we are seeing these results. So to kind of, I would say stratify probably would be a better term than what I was thinking. So if you're stratifying your data that you collected, you can also include the length of stay. So length of stay, it plays very often a significant role in cases like C. diff, where we do see that people who get C. diff, they have a extended length of stay, but you also can look at your cost infection and cost of infection, or also looking into, when you're looking at the cost of infection, what I'm trying to say is also not just the patient necessarily related, you're also looking at additional staff, additional cleaning, additional PPE. So you potentially could be looking at all of that information as well. I actually, as I'm talking to you guys, something popped in my head. I will see if I can pull up a report for you that I worked on. It was a C. diff cost that I had broken down for somebody, and I'll see if I can find it right towards the end of this class. I will give you a break in 5 minutes, so I will be looking for that. So in your long-term care facilities, we kind of don't have necessarily same surveillance systems. We are not looking at the same problems always. One of the things that you would never be looking in your long-term care facilities would be your surgical site infections or cesarean and that sort of a thing, because they're not offering those services. But you would be looking into anything like acute respiratory infections or multi-drug resistant organisms. Quite frequently, they deal with a lot of skin and soft tissue infections, and Vernet's favorite, the UTIs. So when you collect when you kind of land on what is that you want to collect, I should say, one of the not deciding for us. Really, it's not something we kind of pick and choose, I should say. We have to do it. It's the syndromic surveillance for respiratory diseases, and I find that with COVID, this became front and center for across the board, but it became very contradictory, I would say, and conflicting data collection for a lot of people, where we actually have done it in the past on regular basis, and we had systems in place that worked just fine in the past, where we would be asking our colleagues that are in on the unit, hey, you know what, just call me in the morning, let me know, or you would provide these spreadsheets for them and they would be faxing them to you with again the same idea like line list. Is just a little bit of less information. So you would have on the heading, you would have a unit, and then you would collect, of course, the patient's names, the MRN numbers, the location, where are they on the unit in terms of beds and rooms, and then also the symptoms. So you can, with these respiratory and GI, I used to give them one sheet, so there is no looking and searching for these documents. So give them on one side respiratory symptoms, on the other GI symptoms, and they can tick that easily off and send them to me in every morning. Sometimes they forget, so you have, it's not that they don't want to do it. I find it's they're just so busy and overwhelmed, and when we are collecting this information, it becomes a bit challenging. So it's good, if you struggle with this, it's good to designate a person who is going to be your contact person, and it's also good to do some type of set time. So I used to go to bed meetings in one of my facilities, and I would meet all the charge nurses in these bed meetings, and that's where I was getting all the syndromic surveillance reports. Of course, if something is critical and happening really fast, they pick up the phone and call us and let us know. But for the collection of this paper stuff, that's how kind of you have to find a way for them that they are triggered to do it. They rarely you find someone saying, I don't want to do this. It's just because they get so busy and overwhelmed, they forget to send them to us. So case definitions, as I said, I posted it in our discussion for today. There's different resources where you can get these case definitions. Public Health Ontario has a document, and at the back of that document, there is a number of definitions, but there is also your public health standards. They have a number of definitions as well. And then there is your Ontario Health Standards, which is mostly working around the staff. However, again, they're speaking about these case definitions as well. So you will find that sometimes these case definitions will vary in the way we handle the staff versus the patients. So some of those will not necessarily be always lined up that they're 100%, but they make sense. Actually, when you read it, it makes sense. So you would, for example, if we are talking about say pertussis, for example. So for pertussis, we would isolate our patients, but not for the, so if you had a staff with exposure to pertussis, we wouldn't be isolating their staff and quarantining them unless they're symptomatic, where we would quarantine and isolate exposed patients. So that's where kind of you have to read up and see what are the recommendations in terms of the case definitions. And then if you are in doubt which case definition to follow, give a call to your public health and they will tell you what to do. They always know which ones they want you to follow. Yeah, I know. It's just like as I said, they get so busy with their regular care jobs, and one thing happens and everything is sent to spinning out of control for them, so they can't really always remember. So as I said, in my past, I would usually find a way to trigger that in their memory, so they know, okay, so it's 10 o'clock, we have a bed meeting, they're meeting with me, they should bring it. And I really never had any issues with them not wanting to share that information. It's just, as I said, they sometimes do get busy, or they forget, or that if there is a particularly assigned person and they go on vacation, someone else covers, you'll find that becomes a problem too. But you can work this out, it's not a big deal. Okay, so when you start doing your surveillance, it's important for us to know whether it's healthcare associated or not, because some of these are imported to us. So it's critical that we know, is this something that we have a problem with, or is this just a burden on our unit, and we have to still follow the rule of isolation and donning and doffing properly, but it really doesn't have impact on whether we are getting into outbreak or not. And I find, um, in my experience, I find a lot of my colleagues would get very stressed out if we get like 4 cases of influenza on their unit, where just because there's 4 cases of influenza doesn't mean that they're on an outbreak. These cases may be that came in from the community. We put them on these floors, and yes, of course, that's a burden, and that alone creates a problem for them, because now you have 4 patients to take care of, and they're infectious patients, and that on its own, it's in itself is a risk, but it does not constitute an outbreak. So I think I find when I come in the morning, I look at the census, I look at the numbers. I always make a point of reassuring them that we are not in an outbreak, that these are just sheer numbers on our unit. And if we start seeing new cases that we are generating on our unit, that's something to be concerned. Okay, so I'm gonna give you guys 5-minute break here, and I'm just gonna see if I can pull up that report to share with you the cost. If you have any questions here, you can put them up here. I think I have been monitoring. All right, so I just want to show you what I have posted on our web page. There we go. So you will see I have set our meetings here so you guys can join next Saturday. And then I put in your schedules as well so you can see this in addition to the calendar invites I sent to you. So that's there. Okay. And then I want to show you this. Okay. So this is the cost estimation for C. diff outbreak. Well, this was actually just C. diff cases in this particular chart. So there's a number of cases that we were reviewing was for this particular year was 507 C. diff cases that were documented in 1 year for us. And then average length of stay was 5.2 days for these patients. And then they spent total days in private room was 6 per. So that's kind of depends on, I think it depends depended on a patient. So some of them were longer, some of them of course were less. But what I wanted to share with you was the cost. And so this was the nursing cost that was the average nurse pay, or in this, that was in 2016, I think I made this. And then we were breaking it down by use of gowns as well and gloves. So, and then that's per unit. That means one gown and a set of gloves, the cost, and then also the other supplies. But what was really interesting when I was actually collecting this information is how much time do they spend in the rooms. And it was interesting to see how the visits to the patient were reduced because people just couldn't be bothered donning and doffing. So when you are looking into time spent on the new case, for example, for IPAC practitioners, so that was we would spend about an hour a day, or if you're dealing with other cases, investigating and following up, it was about 15 minutes per patient. So that's kind of interesting how this cost was adding up. And then if you look at the cost of medication, for example, so Vanco and metronidazole, they're not that costly, but look at the cost of fidaxomicin, or whatever is how they pronounce this. This is an antibiotic that is designed to treat C. diff. So we don't use this one on anything else but C. diff. So it's kind of interesting to see that breakdown. And then also the cost of C. diff test is almost $20. So that's kind of interesting to keep in mind as well. So that was, I think that was including also labor, but I don't know. Some of these numbers you get from the departments that they just can't really shed any light with regards to some of the numbers they're coming up with. So they just give you a number and say, this is the cost. So what behind that, they wouldn't be able to tell me. So some were able to tell me if the final cost that they were providing to me included labor of their own staff, or it was just a sheer cost of a product. So this was kind of interesting to see how much money was, and this is just an estimation. There's a lot of things we don't know. So this is how much money it's spent on an annual basis for C. diff isolated cases. So there you go. Yes, that's expensive, very expensive. But when you need it, right? And it's life-saving. And the sad thing is that not everyone carries that. So right. So I just wanted to share this.
Cornelia,
Yes.
would we need to know cost analysis?
No. I just wanted to share this with you. So when we were talking about previously, we were talking about the reports here and the understanding the burden of a disease and how you will end up in some of these asks from your facility could be driven by these costs. So that's what I wanted to just share with you, that you may be asked to do this, but you don't, not for the exam purposes for CIC, no?
Okay, no problem.
Yeah. So sometimes they will ask you to calculate, like you may be asked to do projections for PPE use and things like that. So it's just like, how do we get there, right? So I just wanted to share. There's just additional stuff for you to tire your heads with. All right. So when we collect our surveillance data, is again back to our good friends numerator and denominator. So those are always going to be in there for us. They're never going to go away. And then also what we are looking is the time. What is the duration of observation, or if it is continuous observation, how are you breaking it down? So when you are collecting information, you're always looking at from either first of month till the end of the month, or for the duration of outbreak. And when you are collating this information and processing the data, you want to be able to identify your start point and the end point. Or if you're extracting from your ongoing surveillance tools, again, you're selecting certain dates, right? And then you're writing reports revolving around that period or leading. Sometimes you will say in month of, I'm going to just make something up in my head. In month of June, we have introduced a new Foley catheters, and they come in with the entire kit comes in, for example, comes with gloves and everything. So now you're seeing suddenly an increase in the catheter associated urinary tract infections, and you may be looking into, was there a linkage there? There is also perhaps looking into some of the events, but I'll get into that as we go through. I want to jump the gun here. So when you are collecting your data, where is it coming from? Usually, as I said, it's your lab reports. That's kind of straightforward, easy. Could be also from your diagnostic imaging. So if they see that there is something abnormal in terms of CTs or chest x-rays, they will give you a call as well and say, hey, you know what, your patient in such and such unit, they came down, they have this ground glass opacity in the right upper lung, you may want to follow up. So some of those you may see as well. Also, when you're looking at your charts, you will be looking for these results that are already there in your diagnostic imaging reports. You may be looking also into your use of antibiotics or use of medication. And the chart reviews, there can be both, but we kind of do it retrospectively. It's kind of prospectively, it's just pain in behind, really. You kind of have to go every day, review the charts, put them right back. But retrospectively is what we tend to do more frequently. Cardex is another source of information for us, going down on the units and looking at the nursing cardexes. I find they're less and less in use every day, and not everyone is actually doing so good. I think with a lot of electronic charting, the data that is in the cardexes is somewhat questionable, I would say. Also, and so they tend to kind of focus on charting directly into electronic charts, and this kind of is I'm finding them going kind of sideways. Rounding is another really, really good way to collect your information. It is time consuming. It does depend on your relationship with your frontline staff and how they're relating to you. Are they comfortable telling you? So I think rounding does enrich and deepen that relationship. At the same time, but it's kind of, you have to go through those growing pains where they're just not comfortable having you there all the time, but once they see you every day, they're just like, whatever, there comes Burnett, there comes Marina. They don't want to wrangle us, they just doing their business and chit-chatting. And sometimes you can have a more informal conversations with you where they will tell you. I just find that with the way I worked over with different people, you kind of have to follow their dynamics and fit into their culture. So there are places where they were so used to me and reporting in to me face to face, one on one, so to speak. Others would be just calling me and say, hey, you know what, Leonard has diarrhea in room 3. I collected the specimen and I sent it already down to the lab. Others would text me, some would email me, and some would never talk to me and never tell me what's going on. You have to kind of fight for information. So it's a mixed bag. You're dealing with people, different people, and different cultures and different personalities. So, but I find it always interesting that in a same facility, you will come across cultures that are completely different from unit to unit, and there can be sister units, and one unit works this way, the other one works that way. I find I'm very flexible with the way they're reporting to me. I don't really sweat it as long as they let me know and I need to know, so I kind of work with them around that. But I personally love rounding and love going out there and seeing what's going on in my unit and just be there and work with the frontline staff. Not everyone is the same. This is just what I prefer, and as I said, it doesn't make it um, written in stone or a rule. It's just the way I work. So for your e-screening, of course, that's your electronic charting. That's kind of easiest to get the stuff out. And again, depends on the quality of the system your facility is using. What you can get out of it is depending on that, and also depending on what is practice in charting. So I find quite often these systems offer more than we use. It's just a lot of different documentation, puts a lot of strain on the frontline nursing to document. So they always will say, we're spending so much time documenting, we don't spend time with our patients. So that's one of the downsides of it. But the good thing about the reports is that we have access to it and we can extract it really quickly. Right? So this is our old friend. You guys have seen this one before. It's our 2x2 table. So I started off with this cyclospora business with Sharon and Marina, and I'm sticking through it till the end of the course. So it's always going to be cyclospora and Marina's favorite topic and Sharon's favorite organism to cook in her baking, rather. Okay, so people who ate raspberries got cyclospora, so you guys got all of that. How are we getting these? So you always, when you break it down, when you break down your 2x2s, you have them in kind of rows and you have them in columns. Yes, it's small, kind of doesn't really hit you that way to think about it in terms of rows and columns, but that's what it is. It's a small table. So you have your sensitivities and specificities, and you will know when you're looking at this. Always think about it the way, if you kind of are more a visual person, think about it as a checkers board. So, and I color it that way for you. So the diagonal A and D are your true positives and true negatives. And then your diagonal B and C are your false, right? So whether they're false negative in the actual truly positive population or false positives in your truly negative population. So again, this is something we will be using. I find you probably have had more exposure to this with COVID and everyone actually talking about the quality of the specimens and the quality of the tests and speaking about the true positives and true negatives. So when with COVID, for example, when you're talking about the tests that we are running, they're PCR tests. They're really good. But what PCR does, it will pick up also on a dead virus, right? So if you say had an infection, where are we now in July? So say you had an infection in May, and now you're recovered and we swab you, there is a very good chance that you will test positive. So you're looking into these predictive values, and you guys know that when ministry communicated to us with regards to the PCR test, they say, when are we considering these tests positive and when we should be considering these tests negative. So you're always looking at your patient's symptomatology. So, and then of course the history. So if you know that patient had a virus back in May, chances are that we are now picking up on this that virus. So then you start looking into CT values, for example. And CT values, I think everyone knows what it is. It's a cycle threshold. It's the number of times the machine has to turn around to detect the actual DNA or RNA or whatever it is that we are testing in the specimens. So with this particular CT values, you're looking at the cutoff values, right? So different machines, different numbers, and again, the Public Health Ontario came up with a document that gives us very clear instructions, what's positive, what's negative. And then also when they produce a report, they will tell you CT value of whatever and what that means, how they're interpreting these values, because sometimes the number doesn't mean much for a lot of us in frontline. So you have to tell me what it means when you put this number of 27, 35, 46, and what have you. So you're looking at, now we know that this patient had tested positive previously. We know also from the information that's been shared with us and the experience that we had over the last almost 2 years now, that most people do build up immunity through exposure or immunization, and then that immunity is valid to a certain point. Different countries have a different cutoff, so to speak. In Canada, we know and we talk about likely immunity of 6 months, but because we in Canada like to be a little bit more cautious, we say with certainty 3 months you can't get COVID, but we will still be watching you. So now with different variants, we have kind of reviewed that as well. So any variants of concern that came in, so we know that well, there is a very good cross coverage between the wild strain, which was your original strain that came out when that was the first one that we were dealing with, and then once we started identifying these variants of concern was UK, and we know that these two have a very good cross coverage, and that if you had one, I haven't seen, I don't know if anyone has seen, and there is no reports that people actually had both. Brazilian is a little bit different. You could have UK and then get reinfected with Brazilian. Now Delta virus has entered the scene as well in a big way, and we are learning as we go. But what is my point is that when you're looking into your results, what is that you are looking at? Are you looking just at the result, or you're looking into these predictive values? So you have to be aware of your predictive values, whether that person either had a disease or had a known exposure or is a part of an outbreak. So even if they're asymptomatic, now this bears a really huge part on your decision making in interpreting these results. And sometimes they're very straightforward. Sometimes you just kind of like, oh yeah, my patient had fever, shortness of breath, they're showing abnormal chest x-ray, they have a household member who tested positive for COVID, now they're positive, these CT values are relatively low, so you can say, yep, this all adds up, it's very clear cut. But sometimes this information becomes very convoluted and very confusing, so you start to kind of question and have to dig deeper, and sometimes we just have to redo the specimens, redo the testing to determine the whether this patient is truly positive or truly negative. But from your identifying your sensitivity and specificity of data, this is where you're kind of landing, what you're looking at sheer numbers, and then you can look at your predictive values, you can calculate that, but it doesn't really always lend itself in a clear cut to us in the real world, right? So it's always a little bit of that human component that comes in, and sometimes life likes to throw us a curveball. Yeah. So anytime when you are unsure of interpreting your results, I would say consult with your infectious diseases physician. They also are able to have conversations with the patients. You look always into data that may be available to you from, in terms of, was your patient a part of an outbreak, can you retrieve information of their previous tests, and so on and so forth. So you kind of have more ammunition than just your lab result that came in and it's a standalone piece of information. So the more information you can gather, you're getting a better quality assessment, I would say. So did I like take you on a completely wrong journey here, or are you following me through this? Did I lose anyone? Sharon finds it interesting. That's good. Okay, good. So your surveillance can be either active or passive. So generally, we kind of tend to do more of active surveillance, I would say. We kind of get more involved as IPAC. We are looking for healthcare associated infections. We are looking for MRSAs. We are looking for flus. We are looking for COVIDs, of course. But so that's kind of, we are searching for it. I have a picture here, and ever since I ever took my first epi class, there was some kind of image of the iceberg that was shown to me, and I'm sure you're in the same position. And usually people speak about active and passive surveillance as active going deep under the water and actually searching, so you will be able to see the top of your iceberg and what's hidden under the water, where your passive surveillance is kind of like a little boat circling around that iceberg, and you only see what's above the water. So if that's something that helps you visualize how much more data you will get from active versus passive, I'm happy that I put that in. I just kind of, every time someone talks about this, I see the iceberg and I think, oh no, the iceberg again. But with passive surveillance, also you will find that it is cheaper, of course. It's not as costly for the facilities, and often is something that is already there. So you would be looking at the information that you can get from your colleagues, your frontline staff that is actually dealing with the patients. It can be tasking on them though, because they're the ones now kind of responsible to get the information and share it with you. Oh, thanks, Burnett. Okay, so your surgical site infections, that's your process surveillance, and you're reviewing the adherence to practices. So with your surgeries, there is always very, very clear and very prescriptive processes that are in place. So it's a lot of check boxes to tick, so to speak. So they're always hitting all these check boxes in terms of prep, in terms of actual surgery and a follow-up. So they have very structured approach to what they do, and that kind of helps us really with when we are doing any of the surgical site infection surveillance, because everything is so neatly documented and they have always a step-by-step process and they follow that through, and it's easy to identify these gaps for us. So the risk for the surgical site infections, of course, is your bacterial contamination, which could be from the patient themselves. So it could be the skin contaminants, could be injuries, but you also are looking into the wound factors. So this is something that I don't know how many of you are familiar with this. And then, of course, the host susceptibility. So next one I'm going to show you. And if you get comfortable with this particular information, I will tell you this carries a lot of marks on CIC exam. I was talking to some of you saying the not all questions are worth the same in your CIC exam. So you will have something like a simple hand hygiene question, which may be like weighted as 1 point, but once you get into these surgical wound classifications and cabbages and what have you, like your cardiac surgeries, and you are able to analyze the question that they're asking you and determine based on this classification. So you have to memorize this. There's no different way than actually memorize these classes of the wounds and then what type of wound. So when they present you a case on the exam, you're kind of looking at, it's like, okay, so it's a genital, uninfected urinary tract surgery, so that's clean wound. But if you're looking into something that is old and traumatic or has some sort of already necrotizing, so that would be likely a dirty and infected wound, so you know that would be a class 4 wound. So now there's a different tables that kind of build this matrix, and you will based on that matrix, you will be answering these questions. So some of these questions will be kind of series, if that makes sense. So they will present you with a scenario, and you will have like 4 or 5 questions stemming out of that scenario. And they bring a lot of points. So if you, and it does sound scary and look scary, but once you kind of start reading it and memorizing it, I don't think it's that bad. For work, you don't need to memorize this. We tend kind of to stick this in our heads sometimes, but more often we have it on paper somewhere hanging off the cubicle that you work in. So when you're looking into your host risk factors, so you have what is defined as definite, likely, and possible risk. And then you can see like what are the definite risks is disease severity index, wound infection. So that's definite. You know that there's no ifs and buts about that. You know that old age is a contributing factor as well. But when you're looking into these that are low risk, so malnutrition is not really a high risk, of course. It can be depending on how far that malnutrition is gone. But generally speaking, between obesity and malnutrition, a higher risk is obesity over malnutrition. And then you have the possible risks. So you know that with some of your patients that are cancer patients, they're undergoing radiation and chemo. There is already a lot of damage to the tissue that they're undergoing. So one of the surgeries that comes to my mind is mastectomies after the removal of the cancerous tissue. And for the patients who have undergone radiation in that area and also chemotherapy, there is a very high risk of that wound infection. So often for patients who, after they had a mastectomy, they do implants, you will find that they come with a higher risk of the wound infection, post-surgical wound infections. So that would be one of those examples. And then there is your ASA classification. So all of these three will build this matrix that you have to kind of put in your head and identify where these risks and what they add up to. So this is from your ASA. This is the American Society of Anesthesiologists, and they have their own classification that they created. And so they're dividing these patients. So actually, in reality, there is 6 classes, but the ASA 6 is actually patients who are declared dead, and they're only kept alive for organ harvesting. So I didn't include them because we don't use that for surgical site infections. So you only are focusing on 5 of these. So that's there. So how are the anesthesiologists identifying these classes of patients? Is they're looking at the ASA class 1, which is your normally healthy patients. And then as you're going through these classes, you see that their status is changing as well. So you start from someone who is normally healthy to patients who are moribund or are not expected to survive without surgery. So that adds up to the risk. So when you put all this together, this makes and adds up to a risk of a surgical infections, of course. Okay. So I advise you to get very, very comfortable in these tables, and so you can score high points and on the CIC, and then once you pass, you just forget about it. Okay, so when you follow up with your surveillance, of course, so depending on your type of surgery, that is so you have different types of surgery that would have an infection that's setting itself in a different part of body depending on the surgery. So you will have these requirements to follow up depending on a type of a surgery. So we could be looking as far out as 90 days to follow up. So usually for your superficial incision, you look only for about 30 days. But if you are looking into any deep tissues, you're looking into 90 days, up to 90 days for a follow-up that could affect. So like hip or knee replacements, nip replacements. So if you're looking into something like that, you're looking to a longer period, of course. Yes, I start talking nonsense at some point these classes. I'm sure if you guys are re-listening this, you're kind of scratching your head, thinking what went wrong with me at some point. Or you just start wondering at the beginning of the class, and that would be the safest bet for sure. Okay, so Also, when you're looking into your active surveillance, so think about that iceberg again, right? So we are looking at the top, and now we are taking a deeper dive as well. So when you're looking into one of those processes in your facility, you always look at your formal process of identifying and investigating the infection. So you have to, of course, set your surveillance period. You have to set your definitions as well. And again, if you're not clear on these definitions, always look it up. So um, there is different definitions that are set. You have your VAPs, you have surgical infections. So there is better care for patients now. They set your CLIs, and they also set your surgical site infections and your catheter associated definition. So you can go back to that. So there is always a ways and places where you have to look. Sadly, they're not all in one spot, and who knows why. I think someone in IPAC should just put all these definitions in one document and call it a day without searching around. I think we spend most of the time searching where they are. Once you establish, I think it's not that big a deal, but when you're new in it, it's like chasing cats. Okay, so how do we follow up? So you want to have access, and this can be an obstacle for you. So surgeons can be not non-compliant and not open to this, and I don't know why. I don't even want to get into this. Sometimes it's really hard for us to get them on board to do this follow-up. I've been working in facilities where they will just deny that there is anything going on, and they don't want to do any follow-up, and sometimes they can avoid it, but in the end we have to do it. So that's how that kind of works itself out. You have to do it, and then it just ends up being more painful for all of us because it has to go up the chain of command, and eventually it came down from the top to IPAC to do this. So someone just has to sit down with the surgeon to have them agree to follow up with their patients. But usually we would either call the patients or send letters. And one of the good parts is if these patients come back to our facility so we can track them. But the issue with a lot of these infection is that the patients get so upset, so they choose to change a surgeon, so they don't go back to their original surgeon for follow-up after the infection has been identified. So we lose track of these patients. So if they stay with their original surgeon, we actually can trace this back, but often it does become personal between the patient and the surgeon, so we lose control over that data, for example. So you could also establish a network with your neighboring facilities or the facilities that you know um, your catchment goes to, if they're not necessarily able to be seen in our facility. So where would they go if they're not coming to your hospital? And we know that it's just after working in field, you know where they gravitate to. So it's always somewhere in the vicinity, right? And then you work with your partners in IPAC there and see if they are seeing any surgical site infections coming for rework or cleanup or full reconstruction, so they can let you know. The problem with that becomes again between the two surgeons, and becomes a little bit personal, I would say. So it's hard, one of the hardest surveillance programs that I have been involved in, and not because of the complexity of the, the surgical site infections, but of the complexity getting people involved and willing to have reviews done on their patients. And I will tell you, some of these programs that I've been involved starting them up failed multiple times launching them for that reason alone. So it takes off, and then for some reason somebody does get upset over something and they just don't want to follow up. And often we used modified staff to do this calling because we just don't have time to do the calls. And then that also becomes a little bit, who are you? Why are you calling me? You're not my surgeon. I don't want to share this information with you. So it becomes a little bit interesting actually gathering this information. So whoever is up for to tackle this one, you can let me know and we can talk about this, how to set this up in some somewhat organized fashion, but it's pain in behind. And here I said it. Okay. Okay, so you also can send a survey, and those would be something that would be a package, usually in a discharge package. So you can send that with your patient's home as well. But as I said, it's a lot of moving parts to put in line. So with your respiratory, I think this is something that there's no person in this class that hasn't been dealing with some of these, and at least COVID would be one. So usually we are reviewing the bacterial pneumonias. You can see your Legionnaires. I find Legionnaires to be more prevalent in long-term care facilities, retirement homes. Pertussis is another one that you can be looking at. Your aspergillosis, usually linked to constructions, and tends to gravitate and affect more high-risk populations, like your cancer patients. So if you have cancer units or cancer floors, that's usually where you would be seeing a lot of these pulmonary aspergillosis. And then, of course, these lower respiratory, these are like RSV, parainfluenza, adenovirus, and the good old friend influenza that will come back. I promise you, she is not leaving us. So for your pneumonias, there is a very clear definition for that. So some of these, I said, some of them are quite here and there, and you have to look at the rates to establish what is it. But for pneumonias, you have a clear definition. So your patient, when we're talking about the ventilator associated in particular, your patient has to be on mechanical ventilation for over 2 days, which is over 48 hours. So if it's under 48 hours, it does not count. It's not meeting the case definition. It doesn't mean that your patient doesn't have pneumonia. It just means it's not an HAI ventilator associated. So I think this is something that often gets confusing when you're following up. Physicians may be treating this particular individual, but they're not meeting this case definition. So also they have to meet the clinical presentation, of course, of the pneumonia, and you have to have a chest x-ray that supports that as well. Okay, so to obtain these rates, we need to adjust for length of exposure to a device, divide that by the number of device-associated infections. So this is, remember when we were looking at, so it's again your incidence, but you're looking at the population at risk. So population at risk is only people who have the ventilators, mechanical ventilators. So you're not looking at people that don't have these mechanical ventilators in use. So that's your population, and you're looking at the incidence in this population. So that's how you're calculating that rate. Okay, so here is your just for comparison, for example, there, oh my gosh, this is so bad, you can't see this. Okay, so you have your central line associated bloodstream infections and ventilator associated pneumonias. So you can see that you're looking at the numerator is the number of your infections, the bloodstream infections among, say, we picked here ICU patients that have central lines. So again, we are looking into central line associated bloodstream infections, so they have to have a central line. And then you're looking at the total number of days. So remember when I was showing you that calendar that we had, it was Foley catheters that we had in situ. So we had Suganda and Kyle and I don't know how many people I had in that calendar, and Tanya. So there are so many people that we put in that calendar. So you're counting the days. It has to be the days that devices were in use. So doesn't matter is this like central line or catheters. So that's what we are counting on. Oh yeah, and that was another question that a friend of mine told me. She had actually they gave her this question of the utilization of the catheters. So she had to calculate the utilization rates. So which again is very similar to this. It's just a number of days and the number of the catheters that are in situ. So you're looking into these, a little bit different approach to the rate, but it's the same idea again. And then, of course, the same thing for your VAPs as well. So your patient has to have pneumonia, of course. They have to be healthcare associated. So that's the only way you're calculating these. So if you had a patient, for example, that transferred from another facility, came in with a ventilator, and they're coming in with pneumonia, that's not your case. That belongs to someone else's bag of problems. You have to deal with this, no doubt about it, but it doesn't count as your HAI. So I think that's where you have to distinguish some of these things and play some of these cases out in your head and kind of test yourself. But it's important that when we are collecting these denominators, that you are thinking about the devices. So you're looking at devices that are associated, and then you're also looking at the length of time that each of these patients actually was exposed. So that's when we say counting the days of use. Okay. Oh, well, this looks just lovely. I have no idea what happened here. I'm sorry. I'm so sorry. It's good that I entertain myself with this slide. I apologize. Well, anyway, so when you're looking into your ARO surveillance, so it's always expressed in your lab confirmed cases over the number of patient days. So for example, your MRSA, right? So however many MRSA confirmed cases that you have, and then over patient days. So you're looking at how many days were patients in your hospital. So I can be 5 days, Vernette is 2 days, Kyle is 3 days, so that's your 10 days, and then you multiply this by 10,000. I have no idea what happened here. I apologize. This looks like I should be wearing glasses, and I took them off when I was doing this. I know, I'm so sorry. So the denominator is a total number of patient days. We already have addressed this. Sharon, you're killing me. Oh goodness. And then your error rates are calculated and expressed as either monthly or quarterly or annually. Goodness gracious, I'm killing myself here laughing. I apologize. I'm so sorry, guys. So interpretation of your surveillance rate. So when you are looking into so now we've done all the work. Now we have collected the information, we calculated everything. Now what, right? So now this is where your standard deviation comes in play. So now I feel like everyone's putting their glasses back and drinking that wine. was like, oh no, standard deviation again. So the standard deviation is a rate of an infection, indicates the average spread, right? So you could be looking into, remember that fancy formula that I said, after everything said and done, you can actually do this really simply in Excel spreadsheet, but it's how you get, what you're getting out of these numbers, right? So if you're seeing that your standard deviation is further than 2 standard deviation from your mean, it means that it's unusual occurrence, right? So if you see that your rates are 2 standard deviations or more, then that's something that you should be concerned with. So you either high rates that may be leading or indicating that you have an outbreak. So it doesn't say, this doesn't mean it's an outbreak. It just means you should look and identify whether there is a problem. Usually this is where we would say this would be your suspect outbreak or a possible outbreak. So you put the measures in place, but you're not calling it yet. So you want to investigate further your risks. So I'm glad I made you laugh, Burnett. I should do more often these these weird looking slides. I actually don't know what happened there. I have no idea. I don't even know if I could replicate that, but I'll try for the next class. And so when you are looking at these, as I said, these standard deviations that you have more than two or more, this is, you should be looking also at looking back into your chain of transmission, I should say. And obviously I can't even type. I wrote here chain of transmission. It's a chain. And I swear I wasn't drunk. I don't know. Maybe I should start drinking when I do this, because I feel like sometimes I look back at these slides and think, what was I thinking? And if you can't nail down and pinpoint your problems, so you've done everything and you say, I actually don't know why, just like I don't know what happened with my slide before. I don't know why this is. So bring other people in to see what is the problem. Maybe we have limitations in sorting out the data. Maybe we don't know how to stratify. If you can get an access to an epidemiologist, ask them to review your information before you go and present this to the stakeholders, because you always want to make sure that your information, that your reports that you're producing are 100% accurate, and that you can stand behind the information that you're sharing with them, because they will be looking at this and they will be looking at the quality of this information. I swear to you. So here is your standard deviation. This is exactly the same slide we saw last week. And as I said, your numbers are the majority of your numbers, and majority of your standard deviation should be sitting in about 95%. That's how you will find that majority of your data rather should be sitting about the 95%. If you start seeing that your numbers are kind of going this way, then something is not quite right with your information and you have to take a look. It could be that it's just a fluke, could be that something, a blip for some reason, or maybe we just see the tip of that iceberg and we don't know what we are looking at actually. So our HAI rates, as you guys know what they are now, you know how to get them. So now what do we do with them if they're unusually high, right? So you should be looking into this, investigating a cluster or an outbreak. And usually when you as an individual identify something like this, you always have a conversation with your colleagues, with your bosses, with your infectious diseases physicians. So always run this information by somebody to verify that, you know, for your own sanity too. I find it helps. Sometimes I just sound like a crazy person calling a friend, hey, you know what, I'm seeing this. What do you think? Is this something I should be concerned? So you cannot talk it out, because I find it's easier to have this conversation coming down to conclusion when you have a partner in crime, so to speak. And so for any of these HAIs that especially if you're going to have something that you're verging on an outbreak or something like that, you want to make sure that you have your IPAC team and your management behind you, because this will definitely come up with some of the recommendation in terms of practices, or maybe how are we collecting information, or even if you bring in the, as I said, public health before, they may also adjust some of your definitions. So once we start having enough data in our database, now you can kind of look at your rate comparison and do the benchmarking. Usually we benchmark against the provincial or federal standards. You can be benchmarking against other facilities. So a good way to do so is if you go, say, for this Quality Ontario website, and you pull up the hospitals, and then you can see who is similar to you in size and the population. So you can take a look at their rates and see how are you benchmarking against them. I'd be careful with that though, because also we don't always have a good understanding of their catchment population and what is coming in there. So we may not be always comparing apples to apples, but I would say probably your best benchmarking is either against the standard benchmarking, or even better is if you have really good set of information in your own database, so you can actually benchmark against yourself and see how are you doing in terms of improvements. And then, so this is the last one, this when you don't have benchmark. I have encountered this in the past, and this is not something that you would want to hinge your outbreaks or any major recommendations. Usually we use this when we are kind of eyeballing, so to speak, about certain investments. So if you're looking, for example, I'm trying to think about some of these that we were doing. So if you're looking into purchasing certain equipment, and so the purchasing department is trying to justify the cost, and they are presenting to the senior leadership, they ask you, can you tell me about such and such rates in our hospital? So you can say, if you're not collecting this information, you would say, well, we don't have the information, historical information, but we could kind of almost do this like projection in the past based on your current information, and say how you how you kind of comparing in with in line with like recommendations and literature reviews, not government set, but like when you're looking at more like comparing to what is in the literature expectations in certain numbers, or like white papers and that sort of a thing. I hope this makes sense. I'm really struggling to explain this one to you. It's not really a hard fact. So you're kind of really kind of setting these benchmarks against something that is just pulled out of thin air, really. If you ask me, like, here's a paper, and we're gonna benchmark against this, and could be or could not be what we are looking at. Okay. Okay, so finally, the communication piece, and I think we have touched on this across the previous lectures and in this lecture as well. So when you are done with your report, so now we have benchmark, now we know how are we doing in comparison to previous months within our own organization. Are we trending up or trending down, or how are we with regards to benchmarking from the government set? So you have to speak about the numbers and what they mean. Now, usually in these reports, you are going to say, I am recommending, or it would be mandatory to do A, B, or C, or based on IPAC's observation and the numbers that we have calculated and come up with these rates. We are recommending these measures to be put in place. So usually we would say, so we also notice that the hand hygiene rates have been dropping. So we are recommending refreshing the training for the auditors, or maybe refreshing the auditor pool to change and refresh the team. They may be tired and just exhausted from doing this. And then you could also say something like, we would also recommend investigating permanent use of sporocidal on this unit, because evidence showed every time we stopped using sporocidals, C. diff rates spiked. So we are recommending that this particular unit uses sporocidal all the time, so they're not flip-flopping. So depending on your facilities, some of the facilities use sporocidal all the time on all units. That's only one cleaner disinfectant they have. Others will have sporocidal and non-sporocidal cleaner disinfectant. So that'll be one of those scenarios, for example. And where are you disseminating this information? So who are your stakeholders? Where does this go? And now what? That you have created these reports, what you're going to do now, where this goes, how you're going to wrap it up. Other way of communicating is also sharing that information with your frontline staff. So you don't necessarily want to share a lot of that dry statistical information with the frontline. You kind of want to use it in a more simple term, something that translates into their everyday work. So usually in the past, we would generate some of these outbreak alerts, or if there is like an endemic or pandemic, it would be an IPAC alert. So you send these either to the unit or hospital wide. You can usually post them on your website, but you send emails, you print some for people who don't go to their emails when they're at work or ever. So you print some, bring them to the unit so they can read. And usually in these alerts, you want to put some of the immediate actions. So you would be speaking about enhanced cleaning, your surveillance, hand hygiene, increased auditing, PPE. So through the outbreak, this is kind of like your framework, so how to run, so everyone knows. Usually I would send these alerts to the unit, to patient flow, to communication, of course my managers, their directors, that goes without saying, I hope, but also housekeeping, pharmacy, food services, and porters, so they can share this with their own staff, and it's broadly available, so people know what to expect, and there is no surprises for them when they come on the units where you are experiencing an outbreak. You may want to share with them also the dates of the next point prevalence, for example, if you're doing point prevalences, and then also include instructions in terms of how do you want this conducted. So do you want this to be sent, so say for example your lab is coming up picking up samples at 7 o'clock, first one, you want that point prevalence to go out before that, so you tell them at 5 a.m. all patients to be swabbed, all specimens to be bagged together into one big bag and then send that as a one package with the label point prevalence West Wing of White House, whatever, send that down to the lab. And when they're processing, if you have an outbreak number, you include that so everyone can attach that outbreak number for ease of communication, but also expediting the processing of your specimens under those numbers. And then also what you want to do is give them clear instructions in terms of what is our earliest potential opening date so they can kind of know when they can go back to normal. They can plan for staffing. So everyone likes to have some of these some of that information available and ready for them to go so they can plan um, for future, right? So that said, everything said and done, you can pat yourself on the back or not. You always want to review your own system and see how um, how are you performing. So you want to take a look at your efficacies and effectiveness of your systems as well, and also assess how are you disseminating this information. And as I said at the beginning, I find we are not very brave to share the findings. We will follow up on outbreaks because that kind of is a norm, but for the everyday or regular surveillance, we tend to kind of not be very outgoing and sharing this beyond your regular rates that are we are mandated to share. That includes your bloodstream, hand hygiene. We tend not to share a lot of the information that we sit on, and I think we can do better on that. So that's just my personal opinion. I think I do believe that people work better when they know what are the risks and how to prevent these from happening. So when you are producing these reports, make them short and sweet and meaningful. So I was working in one hospital. They were very appreciative of our reports. So we were sending them kind of on almost like a did you know type of questions, really nothing threatening in a way, but did you know that our hand hygiene rates dropped, and did you know that our hand hygiene rates have gone up in past year in comparison to the previous year? Did you know that we have calculated the rates after we have installed the point of care and we are seeing improvement? So kind of we shared a lot of that, and people really like that. Yeah, I think it depends on what the facility has at their fingertips. Usually Excel, I would say, is quite common, but also depends on if your operating systems, where your charts are, so it could be, as I mentioned to you guys before, Epic. They run pretty much on their own. Meditech, you can extract a lot of this information without a lot of manipulation, but quite frequently in smaller facilities, Excel is the king. Yeah, so you review your information, send that out, and sit down with your team and say, I think this is where we are having some soft spots with our surveillance system. We can do this better. Or usually you can see if you missed on some of the outbreaks, or if something has happened and you identify a gap there. So that's kind of easy, low-hanging fruit. So Vernet was saying also that their public health has shared some now a web-based submission for the cases, but I don't remember, was it just for COVID, or is this encompassing all the HAIs or all the cases generally of anything?
Oh, they had produced that during the COVID
Okay.
crisis. Um, but it's used for staff surveillance and resident
Uh-huh.
surveillance. Yeah.
And it's just for COVID, right? You're not submitting MRSAs, VREs, or
No, no, no.
Okay. Yeah, so I think they came up with something to support the community out there, because I think a lot of that information was really cumbersome collecting, and it's more cumbersome managing and analyzing. So for them, it was probably easier to set up a web-based access for you. So you just dump your numbers and they do the magic in the background there. Right, so we come to the end. This is it, guys. So I know the session wasn't the actual lecture wasn't that long, but we spent some time assessing our exam and going through that. So tomorrow, no class. Next Friday, we are gonna get together and have another class, but Vernette is presenting. She's gonna be our first presenter. So Vernette, if you can send that presentation before the class to me so I can upload this and share.
Okay, that's what I was going to ask you, if you will upload it while
Yeah,
I
so I will.
present.
You just get the mic. I think that way is easiest for everyone. So you guys send me your presentation, and as we go through, I will be having them up for you to upload, and then I will share. You will be the moderators. You can flip through your slides, but that part of uploading and all that, I'll do for you.
Sounds good.
All right. So I
Cornelia.
have two people who did not sign up for their times, and they're not in the class. I emailed them a couple of times. They're not responding to me. So if they're listening to this recording, please sign up for your time. You know who you are. I send you emails.
Cornelia,
Yes.
quick question. Okay, so you know how when we do our slide sharing, or you'll give us access to share our screen, but on this screen, like when you try to do videos, are you able to share videos like with sound or no? Because I know you had some issues with it, so I don't want to.
I
I don't
don't
want to
like.
show videos and then kind of get kicked out.
Maybe we give then the wheel to Leonard if there is any videos, because I obviously have been messing up everything, and today was another example of how did we not do well with my screen sharing. I don't know, is it my connection or what's going on, but I would suggest the least videos and all of that stuff, if we can stay away from that. So it's only 10 minutes. I think it's important we stick to 10 minutes, because if we are not done, it affects anyone else coming after us, right?
Okay, so then we can just maybe even just put the link, I guess, for the video.
Yeah,
And
so I think
so-
what you can, if you want to share a video as for the education purposes, I think we can leave that in a presentation so we can take a look at our own time. But for your presentation, it's important that you are speaking about it. And for you guys who I get some people asking me, this is your presentation. It's you picked your topics. I really didn't want to be too prescriptive in terms of what and how to do it, but ideally you want to use this when you are working, and you want to use this as, so it's not wasted. Again, you're spending time in research and making it, so you may want to use this where you're working. So I always think about, as IPAC, you're presenting this to somebody. So you either are presenting to your colleagues in the front line, you could be presenting this to the group of physicians, or to the management. So however you want, really, I'm not prescriptive about it, but just make sure that it's still revolving around IPAC, because we are IPAC. So don't get dragged into the rabbit hole of teaching them about things that they will never need to know, because us as IPAC, we know more than anyone in frontline needs to know about IPAC. So you're just kind of giving them the necessary digested version of what they need to know, if that makes sense.
Perfect, Cornelia. The other question that I had for you is, do we have any information about the final essay that we'll be writing?
Yeah. So that's also posted and open for you since last Friday. So you can access that information there as well. It's on the bottom in your, of course, in your last session. Let me see if I can pull that up to, where am I? I don't know. Okay, here we go. Okay, here you are. Let me share the screen again and try not to lose you all. All right, so it's right here. It's after your unit 14, right on the bottom here. So you can see there are some of the instructions, what you need to write. And then inside here is actually your assignment. Oh, sorry. You have to download this. I don't want to open it now, but there is an actually your topic, what you should be writing about. Where did I go? Where did I just dump this up there? There is your assignment. Do you see that? Okay. If you go in there, yeah. So it's right here. Download that and get going. Get working on it slowly. You should be there, Kyle. Let me see. Did I even send you an invite from my calendar?
Same here, Cornelia. I'm supposed to be on August the 7th. My name is not there.
Not there either.
No. And I didn't get an invite, like the invite that you said from the calendar. I didn't get that either.
So is that you, Jagdeep?
Yes, it's Jagdeep. Yep.
Yeah, you're here. You're on my calendar.
Where? Oh, there I am.
Yeah.
Oh, I only see the beginning part of it. I just
Well,
see.
I'm showing you my entire calendar here.
Okay, on the actual list, it just shows me Simi, and then it doesn't show like the rest who goes after her. Blah blah blah.
All right, let's see what here what you're saying here in this on the page here.
Oh, I think Kyle just said I have to scroll right to find myself.
And yeah, he's right. I don't see him. I have to go and I don't have him even in my calendar here. There you are.
And we just click on that, right, to make it work, like on the green button?
No. This is just for you to see.
Okay.
You guys have filled out that presentation for right here, right? Let's see. On the top. There you are, Kyle. You are 11:30 to 11:45 on the 31st. Perfect. So, any questions?
I'm the only one on Friday.
I know you're the brave soul blazing.
I'm the guinea pig.
You'll be fine. It's fine. You know,
I
it's
know,
just
I know, I know.
and I think it's the best, you know, being first and just
Get
don't
it over
sweat
with.
it. Yeah, get it out of your way. All right. So you guys all set and good? No questions, no stresses, no concerns? Is anyone eating buckets of ice cream? I had someone tell me she was eating a lot of ice cream for the exam. I loved it. All right. So I'm gonna part ways with you guys. And well, you just had wine. So what are you just like eating, drinking, having way too much fun? Okay, take care, guys.